Can you guys hear me now on the Zoom? Oh, perfect. Awesome. Sorry about that. So this chart right here just talks about the 28 OECD countries, so highly developed countries with higher incomes. And they come together, they share stats, share data, and find inadequacies. So if you notice here, this is how much of a country's GDP, so their total economic output per year, is spent on healthcare. So most other countries that are compared with the United States, they spend around 7% or so, 7.5% on healthcare. We spend, or no, they spend around 9%, and we spend around double that at 17%. So it makes you wonder, where is that going to? And this chart shows that. So we spent in 2023 about $4.4 trillion on healthcare, and this shows you who's spending that. So the biggest chunk of the graph is private health insurance. And beyond that, you have two modes of public health insurance in Medicare and Medicaid and CHIP, which is a program for low-income families. And then you have out-of-pocket expenses of 500 billion. So those include any co-pays, deductibles, anything that you're paying out of pocket, whether or not you have insurance, or if you're just paying cash. And then other third-party payer things that includes other public programs like VA, other military programs, other local government things, or like when events happen that reach the news on the local level, where it's like, oh, this patient had this such and such disease, his medication went up by this price, and then suddenly now it's a hot topic, so they're gonna make a program for people with that medication to get it cheaper. So all those random fragmented things fall into that category. But you'll see here that even within the public sector, there's so much fragmentation and so many different sources of funding, so many different sources of revenue, and that causes so much room for inadequacies and inefficiencies, as we'll see later on. As far as distribution of healthcare spending, the biggest things you want to see here is for the United States, we spend around $10,000 per capita, so per person on healthcare, $10,000. Other comparable countries in the OECD spend about half of that at 5,000, while not having any worse outcomes at all. You see, like they have typically better outcomes. Two things they want to note is the green segment on the pie charts. Other OECD countries are spending around 3% of their healthcare expenditure on administrative matters, while we spend 3 times that at 9%. And they spend around 20% of their healthcare expenditure on long-term care. So that's people in hospice, people who are receiving longitudinal care and like nursing homes and things like that. We only spend around a fourth of that at 5%. And that kind of speaks to like the fragmented care system that we have. Like we wouldn't have things like RFC, we wouldn't need RFC or other free clinics if we had a system where people could actually get longitudinal care long term. This graph here, this is pretty interesting. It shows the number of physician jobs in yellow here. It's a very tiny sliver, and the growth of increase since the 1970s. Relative to the amount of managerial, like bureaucratic positions in healthcare, people who litigate, people who talk to different insurances and figure out co-pays and negotiate prices. You'll see that while physician positions have increased linearly and very modestly, the amount of managerial positions have increased by about 3,000% since the 90s. And that shows you where a lot of the money is going and where a lot of the expenditure is going, not towards healthcare, it's not going towards us. Patient or physician salaries have only stagnated, and it's not going towards patients because patients' outcomes are mostly stagnating or declining. So you'd expect with all that expenditure that things would only improve over time, but if you see from this graph, again, comparing us to other OECD nations, starting in the 1980s, we had comparable life expectancies. And while ours have increased as well, even relative, like over time, other countries, you'll see the graph only grows. And then during COVID, you'll see a very large gap. So the US life expectancy is currently about like 4 years shorter than other comparable countries. And you'll see a really large dip in 2020 during the pandemic, and that speaks to like how our kind of lack of longitudinal care kind of leaves people in gaps, and they're not able to get care. Let me skip it on. Okay. Furthermore, more evidence, just like avoidable deaths per 100,000. You'll see we have trended downward and we've plateaued over the past decade relative to other countries. Other countries have started at a lower amount and they've only decreased further. So the rate of change and the overall number has decreased substantially. You'll see another large spike here during COVID. I think COVID is a great like expose in our system because that's when things really falter. And that's when you see that where all the mistakes are, all the mismanagement in the system is. You'll see a really huge spike in avoidable deaths per 100,000 compared to most other developed countries. And this one's really important, at least for, I think a lot of you will find this one very interesting. The maternal mortality rate in the United States is multiple times fold higher than other comparable countries. And even when you stratify by factors like income, there's still a racial disparity that you can't get rid of. So Black mothers tend to have much higher mortality rates, but regardless, you'll see very, very disparate amounts of maternal mortality per 100,000. So the US is the only high income country that doesn't guarantee some kind of coverage to its citizens, some kind of universal health coverage, either due to like a mandate to buy private insurance that applies to everybody and that's super subsidized, or through like universal healthcare, either through a top-down system the government owns the healthcare process, or just through a private or a public insurance system. So out of all the 28 OC countries, it's the only one. Yeah. So when we talk about as physicians that we will treat all patients equally when they come to us, and we will treat everybody with dignity and respect, that can't just stay in the clinic. I think like a big part of that is also advocating for patient care. Beyond that, there's systemic problems that we're not entirely powerless to fix, even though they're very difficult. There's a lot of advocacy that you can do as a physician. And there's a lot of systemic changes, especially at the school. I feel like the school is very diverse in a lot of nice ways. I didn't expect this many people to show up to this at all. I think at most other schools there would be this many people either. So I'm very happy you're all here. But it's important to understand like these systemic problems start being fixed from the bottom up, and we're going up the ladder right now, and we can't just like pull the ladder up with us. We have to help people. We have to elevate healthcare as a human right for everybody. So now I want to talk about some options for alleviating the problem. So Zach's going to talk about single payer.
Okay. So now we're going to get into single payer, which I think the majority of you have not heard about or are unfamiliar with. And just to reiterate, it's also called Medicare for All. So if you've heard that, this is essentially what we're talking about. And just to recap what Zane said, we have the highest healthcare spending, we have the worst outcomes, and on top of that, not everyone in the United States has access to care. So those are going to be the problems we're seeking to address with single payer, and that's what this presentation is really going to focus on. So what is single payer? So it's a single publicly financed and managed health insurance plan. So what that means specifically is that all the insurance companies you can think of, Medicare, Medicaid, everything's going to be consolidated into one health insurance plan. And I'll get into the reasons about why that's beneficial. But I first want to point out that it's just the health insurance side of things that is going to become under public control. If you want to be in private practice, or any hospital you can think of will remain privately owned and operated. It's just who's paying for the healthcare that'll become publicly controlled. And so what is the benefit of that? So as Zane alluded to, the amount of administrative bloat and costs in the United States is pretty much astronomical. When you think of a prior authorization, you might think of how it might impact patient care, but in reality, it also increased costs because there's like an office would have to hire 2 to 3 people just to deal with the insurance prior authorizations, on top of the people that have to verify people's insurance are still active. All these things, they add up and they cost a lot to our healthcare system, and that's money that's not going towards providing patient care. And then specifically, what's covered within a single payer system is everything right here. It's pretty much all medically necessary care. And I do want to point out that under the current proposal, there'll be no point of care payments, which means co-payments, co-insurance. When you go to the office paying $50, gets taken out of the system entirely. And this diagram on your right is just showing how it goes from very confusing to very simple. Businesses, corporations, and people pay taxes to the government, and the government is the only person paying for healthcare in the United States, and that would be allocated directly to us as future providers or hospitals who will get reimbursed. right from the government. Okay. So we're going to be expanding care to everyone, right? You think it would cost more. It seems kind of paradoxical that other countries provide care to everyone and pay less to us. So what is kind of the driver behind why that happens? So first thing, which should come as no surprise, is it decreases the amount of administrative costs. So there's been lots of studies. UCLA and UCSF have done a lot of research on this, as well as the CBO, the Congressional Budget Office, which is the government, about the savings that can come from implementing a single-payer health system in the United States. And universally, it's recognized it's going to decrease costs. The main argument against it is it's a big push. It's very difficult. We've had the system we've had for a long time. Is it really possible? But so getting back to the administrative costs, the CBO estimated that in 2030, $500 billion or $500 billion a year would be saved just in administrative costs alone. So that's very significant. If you think about what you could do with $500 billion, it's almost an astronomical amount that's difficult to comprehend. But the second, and arguably just as important, is we'll finally have the ability to leverage on behalf of the 300 million Americans in the United States. So this is getting to the idea of when you go to Costco and you buy things in bulk, you get a better price, right? In the United States, we've never been able to do that at an effective level. Even within our government plans like Medicare, there's been, you could call it shenanigans, you can call it corruption, but specifically Medicare has never been able to negotiate the price of drugs on behalf of all of the seniors in the United States. And what that translates to is we have the highest pharmaceutical and drug prices in the entire world. So when you think of, and I'm sure pharmaceuticals is when you think about corporate greed or, you know, some of the terrible things you've heard about what happened with like Martin Scarelli or things like that, that's kind of one of the reasons behind that. So finally, our government would be able to negotiate prices down and decrease the amount of spending that we have. And yeah, so those are the two. Okay. And then what does this mean for you as an American? We hate paying taxes. It kind of is the ethos of our country. Sometimes it seems people will trade anything for not having to pay more taxes. So what does this mean? And I want to everyone to keep in mind, we already have the highest healthcare costs. So, and countries with single payer pay less than us. So again, this might seem unintuitive. We're going to be expanding access to care. People are going to have ability to get more care, but the average American's cost is actually going to decrease. So how is it funded specifically? Public funding, the current Medicare for All Act, which is a bill that's introduced in the House and Senate, does it based off of primarily a graduated income tax. So the more you make, the higher you pay. And I want to point out again, the fact that this would eliminate out-of-pocket costs in terms of an average American budgeting for healthcare costs. Typically, when someone goes to the hospital, I'm sure you've heard stories like this, patients might ask, how much is this going to cost? Am I going to be able to afford it? Well, they should be worrying about recovering, what they're going to do after. They're more so focused about, is this going to bankrupt me? So with the elimination of out-of-pocket costs, it's a fixed amount that gets taken out of your paycheck every month or 2 weeks, however often you get paid in the form of taxes. There's no increase in like unexpected healthcare costs. And this diagram on your right is actually a calculator that was made in 2019 about what the average American would pay in terms of healthcare related costs under a single payer, which is on the bottom, and then what they currently pay. And they actually saw a twofold decrease in the amount that people would pay for healthcare, the average American, which at the time, I think the average salary was about like $37,000 or $40,000. And I want to point out as well, as I'm sure you've seen on the news, healthcare costs have only increased and risen since 2019, and with the expiring of ACA tax credits, as well as eventually the decrease in funding to Medicaid that we're going to be seeing after the big beautiful bill, if you want to call it that, is implemented. These costs are only going to go up, so it's only going to make more and more sense to implement a single payer healthcare system. Okay, and this is a fun part. Probably you'll enjoy this more than listening to me talk about things. So if you have a beret, please put it on. You have some cool black glasses, also put those on. We'll get into myth busting. And so myth number one, this is probably one you've all heard. It already takes you forever to get an appointment. I'm sure you all dealt with this at some point. Won't this increase waiting times like in Canada? And then graphic myth busting. Okay. So So I want to let you know that in Canada, the care that is delayed is not emergency care. So if you get in a car accident or you hit your head, it's something like that, it'll be similar to the United States. You're rushed in based on priority. People who need care are getting care, but then that shifts obviously to outpatient care. So like the United States, Canada does have issues with primary care wait times, but if you look into the research, you kind of flip a coin to see if Canada or the United States has worse wait times. And then I want to bring that to your attention again. Canada pays about almost half per capita for care, and they also have care for everyone. So not really a good concern. Okay, myth two, I'll lose access to my doctor. So again, everyone's going to be under the same health insurance plan. Every doctor is going to take the same health insurance. I know, and myth busted as well. So, okay. So right now is actually when we have limited choice. So insurance providers, this control costs, will narrow networks. You can't go to whichever doctor. You have to make sure that the provider you're going to is in network. In single payer, you can go to any doctor you want without the fear of it being out of network and having increased costs. So you'll get to go to your own doctor. You're going to go to whichever doctor you want. Okay, and won't this stifle innovation in medical research? Myth busted. Okay. So most of the new drug targets, new things in their infancy, they're funded by the NIH. So when you hear about the NIH funding that's happening, the cuts that are happening today, you hear everyone sounding the alarm. America is going to lose their position as like the innovator in the global stage in medical research. So what the rationale behind that is the NIH funds the breakthroughs somewhere along the line, pharmaceutical or medical tech company will pick it up and then bring it to the public. So the innovations driven by the NIH, and then somewhere along the line, medical tech companies will pick it up. And I want to point out, 9 out of 10 of the biggest pharmaceutical companies spend more on advertising. So when you see those random commercials with people smiling, talking about eczema or whatever, they spend more money on that than they do on research. So if you're really concerned about that, they have money in their budget to fund more research. They just choose to spend it elsewhere. And other countries like Canada and the UK that have universal healthcare still produce very, very meaningful research. So there's already a template of how we could remain medical innovators. Okay, and last one, I know the sentiment is popular as well. It's a government takeover of our healthcare system. Socialism is anti-American. No, this is probably the end of the world for some people. But I want to remind you that as physicians and hospitals, you will remain privately employed. Your decision to provide care is going to be based off of your clinical expertise, which is not always the case in our current healthcare system. And it's only the payer or the health insurance company that's becoming public. So you will still you'll arguably have more autonomy as a provider, and obviously there'll be increased access to care. So maybe you'll also feel like you can do more of the right thing by your patients. Okay.
Cool. Thank you, Zach. So I know you guys probably have quite a few questions. That was a lot of information in less than 20 minutes. But what we're going to do first is do a small group activity. I kind of want you guys to think a little bit about how this impacts or has impacted your life prior, today, or in the future. So you guys are kind of already broken into tables, so this is perfect. Take about 5 minutes just to look at these questions. Pick a couple that you feel passionate about or feel like you have something that you can think of off the top of your head that has happened to you. So a time you or someone you know avoided care due to costs, a time you saw a patient harmed by delays, denials, or insurance networks, a moment where insurance coverage determined the quality of care, or an experience where the system got in the way of doing the right thing. So I'm sure most of us here are actually MS1, so we're kind of new to the field of healthcare, but we've been in medicine for many years getting to this point. We've all done some sort of clinical related activity. So I'm sure we all, even if we just talk about LACE, that is perfect. But I want to take about 5 minutes and you guys can just talk amongst yourselves. And then we're going to have a Q&A and a discussion after this where we can talk more about what this all means. So take a couple minutes. And we'll be going around if you guys have questions or short blurbs or anything right now.
It's just how it works. Like that exactly. Or like that people that get involved back there that she had. So he actually that's good. So true. It's really good. Like I think he already it's still the same housemate. There were medical attention. It's the worth it.
Similar to like.
And I don't get. And I remember most of the time. Girls then we're gonna sit at 7th floor. Separate. Go to the doctor. You're in addition to know the cause because you were so scared.
Yeah.
My boss over my contact. My doctor was. I feel like I always get.
So
Like.
especially when
They ask me to like reach out to every shift. They're really just reading out like I can read it exactly. So it's like they're just in room.
We actually both had two cities. And it was like small world and like off paths, but something that I was like,
Yeah.
she studied humanities. She was like,
red one.
like biology, whatever. It's like,
People would come in and they have like or something. You always have to like check. So like log in for your medical group. Like a lot of time, even if like one time somebody came with a walker, I'm gonna get checked out, but then they're like, oh, there's one. Sorry, delay of care. Like, decided they wanted to pay out of pocket. Yeah. I want to help them.
Yeah.
Just like where you are.
Theories are always concerned with money.
I have one example where say
Very strict office,
I like run a song
like money of.
that like basically like scraped his head. I don't know how it happened. I had to dig to this. It
Like babies. So
sort of like tough. Like my driver.
or like all three.
Yeah, oh yeah, so I was just
Thank you. You don't want to pay for the.
Yeah.
gonna address it more.
I mean, it's not funny in the moment. Like he was like leaning and like
No, give
it looks pretty serious.
Insurance is crazy. Okay, first little story.
sorry.
I went to the dentist. I just need my fillings. Trying to try this thing. I was
Like more serious.
Now that I have medical,
and
I
I had to go. He like there and ended up being getting involved in admin. So I was like, I have two difference too. The fact that you have to like super close versus going like now. That was stressful. Yeah, I remember. I was like, dang it. That crisis is like going back to education to work with like
getting
like a lot of the associates. I could read it afterwards.
Right now, if you don't have a family, you still pay for public.
Know about workers, guys, then they get even worse.
Or to this one.
Not me. Support me. Yeah, like that. You have like that's like you get back. There's a restaurant. Like oh you have a.
Like an added tax.
You're not in the same pool as me or something. They like.
Salaries.
Like the box of
Not coming out with dogs.
He does not know what a pomegranate is.
I think
He knows what.
A lot of room. Because not by engineers.
our systems are.
Insurance with the and we switch those. I don't know.
Like actually credit date. Like
And there's much we a neighbor, but they like what's the other? I think the best systems are the Nordic countries because they're
so it's
Genuinely concerned.
really like that has Yeah.
Why would you keep that?
In the practice, do not make me do that.
I think that's a big thing. Can you change my hair? You have money, it's another country for you to do.
Talk a little bit more after, or?
That's basic, right? I remember that.
In Mexico, you just go full here, right? You don't just
Like a
six.
Oh, has everyone had enough time to kind of talk about it?
Yeah.
Alright, so I don't want to just call on someone start off the bat, so I'm gonna kind of share a story of my own, and then I'll just kind of let you guys roam free and you guys can share. So oddly enough, the past week on my social media feed, I've been seeing a lot of insurance posts. It's probably like tracking what I'm looking on the internet, but so I've been seeing a lot of people complain about the cost of insurance. One particular family, they live in Florida. They have like 2 or 3 kids. One has like more severe medical needs, and they were trying to get quoted for medical insurance. And for the family of 5, it was going to be $5,600 a month to have their premium deductible for the physicians that they wanted to see. And so then I looked in the comments because I wanted to see what people thought of this. And people were talking about how at this point it is cheaper to just bear the unexpected costs of an accident or of a like necessary medical treatment and pay the monthly fees after the fact than have insurance at all. And so a side note, when I was a freshman in high school, my dad was diagnosed with stage 4 non-Hodgkin's lymphoma. And his treatment, by the end of the treatment, was $1.3 million. And so over 8 months, spending over $1 million on treatment for cancer, which is something that we have the technology to cure. And he thankfully did get better with the treatment. And my family thankfully did have good health insurance. So we did not have to pay more than $1,000 out of pocket. But most people in our country don't have accessibility like that. And especially in our community, in the Empire, we have many patients who are going to be losing services like this. And kind of a sidebar as well, we were talking about how with single payer, we'll have the opportunity to negotiate these drug prices. And you probably have seen somewhere on the news over recent weeks that Medicare, Medicaid is negotiating with pharmaceutical companies through the Trump administration in getting GLP-1 medications cheaper. Unfortunately, because of this bargaining, this is going to be great for people who are on Medicare or Medicaid. But IHP, one of our region's most significant insurers, are no longer going to be covering it for obesity treatment. And so my latest preceptor is an obesity specialist, and he's having this discussion with his patients that in a month's time, the patients that are responding very well, losing weight very rapidly with these GLP-1 medications will no longer be provided after the new year. And so by having a collective bargaining of our whole healthcare system, we're be able to get these low drug prices for everyone, saving money overall. And it's just kind of like crazy to think about that we have all this technology and all this money going to medical sciences, yet it's getting spent on ads or bonuses or profits or like the market shares, because the shareholders right now is what's most important to our healthcare system. So my little rant is over, but does anyone have a discussion they'd like to share about one of these points or just something else you have that kind of goes in hand with our current healthcare system?
So during my gap year, I was a scribe at a breast cancer clinic. It was actually Cedars-Sinai, so like, I guess it's a big system. It may play into the story, I'm not sure, but there was a patient who was having developing symptoms and needed to get an MRI because they thought her cancer had metastasized or developed more. And the insurance denied it because she had already gotten that same scan like too soon within the same time frame. So they denied it, and then my doctor was talking to me about how I needed to like word the note in specific ways to make sure that when an insurance company sees it, they see more of a need. And then she had to keep going back and forth with the insurance company. And ultimately this all like delayed her care, delayed the treatment she's supposed to get. And I don't exactly remember the specific outcome in terms of how they're able to get it, but I remember they were. You think about like how this is something that thankfully was able to be delayed, like the time frame that it took to actually get the scan may not have played a significant role in the development of her cancer, but for other patients that have more emergent conditions, like stuff like that can really change the health course of a patient. So that was like one of my few experiences where I saw like how the insurance companies were making it harder for patients to get necessary care.
Perfect, thank you. Does anyone else have a discussion they'd like to bring up?
I was talking about like more like kind of like small scale examples that just feel really icky with like insurance and stuff like that. Is like when I worked in primary care for like vaccines, if somebody had one insurance, their kid just got one shot with all three vaccines versus if they had a different insurance, that insurance didn't supply the 3-in-1 shot, so it would be 3 separate shots. And it's like that just sucks that one kid in this room gets 1 poke and this baby in this room gets 3 pokes just because insurance. And it's like that for like everything, like even like with like colonoscopy medicines, like just because they have this insurance, they're gonna drink the juice that tastes good and is it gonna make them have a terrible night. But then these people, they're just gonna get this like terrible gallon of water that tastes terrible just because of insurance. It's just like it's so weird.
Yeah, definitely. Like the inequities in care, especially because the people who have great insurance are going to get the great treatments and the great comfort, and the people who don't are going to get what is available.
Thanks, Nathan. Yeah, I think that definitely the point regarding the moment where insurance coverage determined the quality of care stuck with me. So during my gap years, I worked at Cedars and at CHLA at the same time. And even though they're within less than a 5-mile distance from each other, the stark difference in patient backgrounds that present is completely insane. So I worked with like pediatric neurosurgeons for both hospitals, and I was able to see how like there's a condition that some children can experience called brachial plexus injury, where during birth, either the way that the child was delivered, there is like some sort of nerve damage that's done to them. And at CHLA, a lot of children were presenting late. They had limited treatment options. The treatment options were a lot more invasive, and the recovery was a lot longer versus at Cedars, it was done a lot more quicker, a lot more sooner, more options. So it's interesting because it's like the more expensive treatments are now going to be introduced in those who present later. So it almost kind of creates this positive feedback loop of like later presentation, later diagnosis, later treatment, but even more expensive, rather than if we just were able to get them in earlier, if they had the option to come in, if they had that early diagnosis where things are more minimally invasive and less expensive.
Absolutely. Awesome. Does anyone else have anything? We've had some good points about how we've seen different delays and inequities in our care. But yeah, you want.
I just had a was telling them a quick example because I help run a soccer league, and so there was like one time where like one of the players got like his head like kind of a deep gash from like one of the cleats and stuff, and obviously none of us there are medical professionals, so we don't know the extent of his injury, but like he was bleeding a lot of blood, or like a lot of blood was coming out of his head, and so like it looked pretty serious. So we asked him like, "Oh, do you want us to call the ambulance, or would you like somebody to take you?" And then his friend was like, "Bro, don't worry, I'll take you. Like, you don't want to pay like the ambulance." And thankfully, like it just turned out like it was just a superficial gash, so he just had to get like staples and stuff. But like somebody was alone, or you know, it was a more serious case where maybe there was like some like I don't know, cerebral hemorrhage or I don't know something, but like. Yeah, it would just like affect that decision of getting the ambulance or not.
Yeah. Awesome. Thank you. Definitely, because questioning the severity of a symptom when you don't even, most of our patients aren't medically knowledgeable. And so not understanding like what is happening, but the first question is, am I going to be able to afford this? Or is my insurance going to cover it? That should never be the first question, especially in an emergency situation. But anywhere in healthcare, it shouldn't be the first question. Just because I know we're running a little short on time, I'm just going to move on and then we can come back if people have some more points. But let's see. So questions. So this meme here, single payer, American people, private insurance companies are pissed because we want single payer healthcare. And then yeah.
Okay, so after this presentation, do you believe we can do better in the United States? Do you believe your patients deserve better? If so, these are two opportunities to kind of get involved in the fight for universal healthcare in the United States. So we're starting a UCR SNaHP chapter here. So you scan that one, and then I'll tell you a little bit about the SNaHP National. So SNaHP National is obviously a national organization. There's chapters pretty much everywhere across the United States. If you saw me and Nathan went to Washington, D.C., as this picture shows, we went with them to lobby against a specific program, but we got to meet people from Johns Hopkins, Emory, University of Chicago, Kaiser, there was some Kaiser people there, OHSU, Oregon. So really good way to network if you're interested in that, aside from the ability to advocate for change. So and then if these three things particularly resonate with you, so educating our community about Medicare Advantage versus traditional Medicare. So we'll have some more information about that. And if you have questions about that, feel free to ask me. Meeting with legislators to discuss health policy. So that's what we did at Washington, D.C. But also our local congressional representative is already in support of Medicare for All. So Nathan and I are interested in looking how we can support him in his push to make sure everyone in the United States has access to healthcare. And if you're also, have more questions after this than answers, we're happy to, we want to start educating not only you guys, but as many people as we can about why our healthcare system needs reform. So if you want to be part of any of those, please send these to us. And then we'll open to questions.
Or you can ask.
Yeah. But I was talking with everyone about how the light seems so far away to where we can get here. So where is our government right now into making this a reality, or is it very far off? Are we? Yes.
So this is not a new struggle. This organization specifically has been around since the late 70s. So what the philosophy is now is like people power is important. Having these conversations is important. Making sure we're all on the same page, that everyone wants our patients to have access to healthcare is important. So if you wanted me to give you a timeline,
If there is one.
there's not a timeline, but bills do get introduced every year. So there is actual legislation that does get introduced. So in terms of that, it's not as far as you would think, but like you said, garnishing the support, convincing people that they're getting a bad deal for healthcare is kind of where we're at in this push right now. But I'm hopeful that as people begin to see how defunct our system is with cuts, the different cuts we're seeing, it's kind of like a boiling pot of water. At some point, it has to boil over. So hopefully by having these conversations, we can capitalize on it.
I do want to add, even though it's very bleak right now, there is, within the past 2 years, there is a progressive trend of many more candidates being openly in support of Medicare for all. Obviously, like Barack Obama was, and then he wasn't. He flipped all of that, but like today, there's local elections where a lot more candidates are in favor of it in Seattle and New York, and then more like state level elections where very popular candidates are in favor of it. In San Francisco, the challenger for the election there is very in favor of Medicare for all. So there's a bigger push now, I think, because the need is so great. So I wouldn't lose hope, and I think joining this organization is a way of being in tune, even if you're not super active, just being aware of what's going on, where we are, and working to day to day to help these candidates out.
And another point is that this is kind of like the North Star of the organization, is that Medicare for all is the long goal. But in the meantime, we can make some strides to getting to that point. But also like thankful for like Sonia and the Health Impact Hub is getting students involved with this kind of work, this like policy work, this like push for improved healthcare access is very important. Because broadly, like across our country, medical students aren't very aware of what's happening outside of school. Like that's like a big deficiency in our current medical school system. And so being able to both treat the patient, but also treat the system that is infecting or affecting the patients is very important. Yeah, Connor?
So I actually have two questions, but it's kind of going off what you're mentioning. So obviously like massive healthcare reform is pretty challenging in the US to do, as you guys were mentioning. What do you think are some small steps that, you know, legislative could make to kind of improve the healthcare, I guess, like economy and market? Like what are a few things that you think could improve like in the short term versus the long?
Yeah. So there's like a really interesting book that I can lend to you guys that I read. It kind of talks about all the band-aids that our current healthcare system has. So like dialysis patients across the country all receive care for dialysis paid for by the federal government. All pregnant patients, they get their pregnancy covered by the federal government. And these are due to famous cases that led to widespread public support. So if someone has end-stage renal disease and you realize, oh, there's a problem here, we need to fix this, so we throw a band-aid on it. And so these are those little policy changes that help fix our healthcare system, but they're not doing anything but throwing a band-aid on like a water leak of a ship. Like it's sinking. This ship is sinking.
We mentioned like the ACA and Obamacare. We actually that was the first attempt at universal healthcare in the United States. And as you saw, it was pretty quickly dismantled. And that's called like an individual mandate. So each person in the United States had to pay for healthcare. And if you didn't, you got a tax penalty. So that would be like a more moderate reform. And as we saw from what happened with the ACA and to the point where we're at now, it just didn't work. And that would have been the least disruptive way towards universal healthcare. So if you wanted to try to do that for round two, you could, but as we saw, history tends to repeat itself. So that's why something like this, even though it does seem like a larger push, it honestly at times seems like the only way we can really guarantee healthcare to everyone.
And then also another thing is like when we say meet with legislators to discuss health policy, obviously we're encouraging them to sign on to the Act of Medicare for All. There's also policies separate from this. So when Zach and I were in DC, we weren't talking about Medicare for All directly. We were fighting for the WISER model, which is a initiative through Medicare to introduce AI in authorizing prior auths. So it's a test that was supposed to come out early 2026 in 6 states for 6 years to see if AI could efficiently approve or deny prior authorizations, which the research shows it's not very accurate. So that was one of the things we were encouraging him to sign on for, or to sign against. And then another one was educating them on a recent report that the Physicians for National Health Program, like the parent organization, is publishing, talking about how Medicare Advantage plans have racial inequities. So they intentionally target communities of color, and it inefficiently. We're gonna have a whole talk on this actually in the new year. So it's much deeper, much more complex than getting a one-word spiel, but it talks about how Medicare Advantage versus traditional Medicare has very racial issues with who gets what kind of care at what cost. Yeah.
I did. So I haven't really heard anyone talk about this yet, but I'm just curious, because we know that the US has a pretty significant physician shortage and it's only going to get worse. I'm curious if a single payer system would either help, I guess, relieve the physician shortage or exacerbate it.
Yeah, I heard this from multiple groups when walking around, and I think the thing you should look at when you think about that is what is the biggest problem that physicians mentioned when they talk about their jobs? If you look at a lot of like studies, polls, everything, insurance, it's like a really big problem for physicians. It causes so much friction, it causes so many delays, it causes so much job dissatisfaction. So at least from that aspect, I think if you make a job more appealing, I think the two biggest barriers to people wanting to become physicians is how long it takes, obviously, and the financial burden of taking out loans. And then when you're actually in the job, you're not free to take care of your patients the way you see fit because of the insurance burden that everybody understands. Even non-physicians know about it because they're patients at least. So I think it can alleviate that somewhat.
Yeah, sorry, last part, but Dr. Piana talked about in our last HESJAR model about moral injury. And that's a significant burden, like what Zane was saying. That just kind of put a word on what physicians are feeling. This is the burnout that we're experiencing because you never want to have to go to your patient and say, I'm so sorry, we're not going to give you this rheumatoid arthritis care because your insurance doesn't cover it. Day after day doing that to your patients, it's not great for your like moral ethos. Like this feels terrible and it's leading to this burnout or fighting with insurance companies to get the care. And so hopefully the research shows that if we did remove the barrier of insurance, it would lead to more people feeling somewhat optimistic that our healthcare system is actually working and not being jaded, like Dr. Pina was saying, about how the system is set up to fail our patients. But yeah. So if you guys have any other questions, we're over time, but please come up to us. Please talk to us. Please join us for our next sessions. We're going to have one in January. But thank you so much for coming, guys.
Thank you for coming. The round of applause was also for yourself. There's so many things you could have been doing right now.
Guys. Hey.